All right, welcome to The Explainer. Today, we're diving into a high-stakes survival guide for the respiratory matrix. We're going to explore three major clinical battlegrounds where precision, literally, is the difference between saving a patient and causing catastrophic harm. So we aren't just going to sit back and be passive observers today, no way. We're stepping in as the clinical judge, and we're demanding a strict structural audit of the facts on the ground. Let's get into it.
To see exactly what I mean, let's start with a classic 50-50 dilemma. How do you distinguish between two conditions that both present with a complete bilateral whiteout on a chest x-ray? Picture this, a clinical lawyer, someone who just glances at the surface level evidence, sees those bilateral infiltrates on a film and boom, immediately cranks up the loop diuretics. They just assume, oh, it's fluid overload, without even checking the data. Well, as you'll see, jumping the gun like that without a strict audit of left atrial pressure, that can be a fatal error.
So, to make sure we never make that mistake, here's our roadmap. First, alveolar collapse, ARDS versus edema. Second, the ventilator pearl regarding ideal weight. Third, airway resistance and flow volume architecture. Fourth, pleural crises and transthoracic trajectories. And finally, surviving the boards. All right, part one, alveolar collapse, ARDS versus edema. Let's dive deep inside the alveolar capillary barrier to see exactly why it collapses.
Now, what's really fascinating here is how sharply we can draw the battle lines between ARDS and cardiogenic pulmonary edema. Remember that clinical lawyer we just talked about, the one who handed out diuretics like candy? Well, if the patient actually has ARDS, we're dealing with non-cardiogenic pulmonary edema that's driven by an inflammatory, neutrophil-mediated injury to the alveolar capillary membrane. There is absolutely zero evidence of left atrial hypertension here. The echo? Normal. The BNP? Completely normal. And this is the kicker. The pulmonary capillary wedge pressure is less than or equal to 18 millimeters of mercury. Cardiogenic edema, on the flip side, has that elevated wedge pressure and actually responds immediately to diuresis.
So the absolutely crucial point is knowing exactly when a patient has tipped over into ARDS. By definition, this presents within 1 week of a known insult. Think sepsis, pneumonia, or massive trauma. But here's your ultimate diagnostic tipping point, an acute onset of reduced oxygenation, where the PaO2 to FiO2 ratio, meaning the ratio of arterial oxygen to the fraction of inspired oxygen, is less than or equal to 300 millimeters of mercury. 300, that's your magic number.
When you're in the heat of the moment, you've got to perform a strict signal versus noise audit. A borderline elevated systemic blood pressure, that is pure noise. Just ignore it. The true signal you have to zero in on is profound hypoxemia that's completely refractory to escalating supplemental oxygen. And why doesn't the oxygen work? Because all those fluid-filled, consolidated, or collapsed alveoli are creating a massive intrapulmonary right-to-left shunt. The oxygen literally cannot cross the barrier.
Which brings us to a massive yet honestly super common error. Managing an ARDS patient with liberal fluid strategies is just a dangerously dumb mistake. Here's why. Because the endothelial barrier is already damaged and highly permeable, pumping the patient full of fluid simply accelerates protein-rich exudate filtration straight across that membrane. You are literally worsening the alveolar flooding. Instead, you absolutely must implement a strict conservative fluid balance. Okay, section 2. The ventilator pearl, ideal weight. Now that we get the pathomechanics of ARDS, let's look at this critical executional pearl. Let's challenge the rote memorization of mechanical ventilation for a second. When a patient goes on a ventilator, how exactly do we calculate their tidal volume parameters? Think about it. So, the most frequent execution gap, both on the wards and on the boards, is calculating tidal volume based on a patient's actual body weight. But think about the physical structure of the human body. Alveolar volume is structurally predetermined by height and biological sex. Adipose tissue doesn't grow new lungs, right? Therefore, you must use ideal body weight, or IBW. If you deliver tidal volumes based on a patient's high actual weight, you're going to overdistend those alveoli and induce fatal, iatrogenic, ventilator-induced lung injury. We call that volutrauma. To prevent this, there's a mandatory protocol metric you just have to memorize. You must calculate a target of exactly 6 milliliters per kilogram, strictly using that ideal body weight, every single time.
Moving right along to section 3, airway resistance in flow volume architecture. Time to shift our focus to respiratory circuit geometry. When we map out the flow-volume loop kinetics, it brilliantly illustrates the diagnostic dividing lines of airway resistance vectors, basically the difference between obstructive and restrictive physiology. Your tipping point here is the FEV1 to FVC ratio paired with the loop architecture itself. In obstructive pathomechanics, like asthma or COPD, that ratio drops below 0.70, and you see a characteristically scooped-out expiratory limb. It literally looks scooped out. But in restrictive diseases like interstitial pulmonary fibrosis or sarcoidosis, the ratio is normal or even elevated at 0.70 or higher. And the architecture? It shows this symmetrical, narrow witch's hat profile because there's a proportional reduction in all lung volumes.
Okay, let's move to the severity matrix and see how this builds into an actionable plan for our obstructive patients. Step 1. If they're stable with a normal PCO2, you just manage them with scheduled inhaled bronchodilators and low-dose systemic corticosteroids. Easy enough. Step 2. Emergent. If it's an acute asthma exacerbation with a rising PCO2, which indicates fatigue, you need non-invasive positive pressure ventilation. If they happen to be intubated, you've got to optimize that expiratory time using a 1:4 ratio to prevent auto-PEEP. Step 3. Critical. If your intubated patient is suddenly hypotensive with rising peak airway pressures, they have high auto-PEEP, inducing a massive mechanical tamponade effect. What do? You must immediately disconnect them from the ventilator circuit to allow for complete passive exhalation.
And that brings us to another terrifyingly dumb mistake: setting high tidal volumes in an intubated patient with severe bronchospasm just because you want to correct their hypercapnia. Listen, doing this just traps air, generates catastrophic auto-PEEP, and precipitates barotrauma or even cardiovascular arrest. You simply cannot force air out of clamped-down airways. Instead, you have to accept permissive hypercapnia. Just let the CO2 run a little high to save the lungs.
All right, Section 4, Pleural Crises, Transthoracic Trajectories. Let's move up to our final anatomical battleground to evaluate acute unilateral chest asymmetry. If a patient comes in with a structurally asymmetric chest, you're usually choosing between a tension pneumothorax and a massive pleural effusion. And here's the really fascinating part. In both of these crises, the trachea shifts away from the affected side. So, how do you tell them apart? The physical exam is your tipping point. A tension pneumothorax forces air in via a one-way valve, creating positive pressure. You'll find hyperresonance to percussion and systemic hypotension because all that pressure literally compresses the vena cava. A massive pleural effusion, on the other hand, fills the hemothorax with fluid volume. So there, you'll find profound dullness to percussion, but generally stable hemodynamics.
Finally, Section 5, Surviving the Boards. Let's transition to our final segment to see exactly how this clinical matrix gets testing. Consider a classic medical board practice scenario. You have a patient presenting with an X-ray showing bilateral pulmonary infiltrates. Sound familiar? Based on their acute onset, diffuse inflammatory lung injury, and hypoxic respiratory failure, they are absolutely suffering from ARDS. Now, the correct answer here is intubation and mechanical ventilation. When a patient is apneic, hypoxic, and failing less invasive means, you just have to secure the airway to ensure adequate oxygenation. This isn't just arbitrary trivia, guys. This is exactly why the structural knowledge of ARDS pathomechanics and ventilator management we just covered is absolutely essential.
So I'll leave you with this final thought to chew on the next time you look at a chest X-ray or stare at a ventilator screen. When faced with a complex respiratory crisis, will you be the clinical lawyer who superficially assumes fluid overload? Or will you be the judge who strictly audits the physiological tipping points? Mastering these frameworks means you aren't just reacting to random alarms, you're actively controlling the respiratory matrix. Keep auditing those facts and keep learning.